Okay, time for us to touch base again on our review that we've been doing for this year. We're looking at the Millennium Development Goals. The deadline for achieving these goals was June of this year, 2015. So we've been taking them one by one just to see how Ghana did, basically, our performance, whether or not we measured up to the global goals, and where we're looking forward to going forward. You know, because we have sustainable development goals now, new goals that have been set forth by the UN. And so we're here to talk to two, when I say experts, I think it's even an understatement.
Erudite.
Very erudite individuals. Okay, so ladies first, Dr. Kezia Mom. I don't know why this acting is still in front of her title, but fine. Acting Program Manager for the National Malaria Control Program. Hopefully the acting will be removed
It should be
because
removed.
she's so fantastic.
It's a waste of time.
Good morning, Dr. Mom. Good morning, Dr. Mom.
And
It's great to have you back on the sofa again. And the Chairman General, Mr. Girmay Haile, is the Country Director for UNAIDS in Ghana. Also wonderfully erudite and a wonderful resource person always. And thank you for making time to join us for this all-important discussion. Okay, so how did we do? Anyway, well, no, just kidding. For the people who may not know, MDG 6, Millennium Development Goal 6, was about curbing HIV/AIDS and malaria and other diseases, which is why we have the director of the Malaria Control Program and the country director for UNAIDS here, because those were the two main diseases specified in the goal. So we're going to ask them what our report card looks like. So we'll start with you, Dr. Ma. We've had wonderful information from you in the past about what your program has been doing to combat malaria. Now, when you look at the goal itself and what we're supposed to achieve by June, how did we fare?
Before Doctor comes in, I think I need to put some records straight here.
As
I was growing up in school, we never heard of the team Chelsea. How times have changed. Now it's become so important. Even clever people like you are rooting for Chelsea. It's very interesting.
No, we are not rooting for Chelsea.
No. You need to understand football. Football begins and ends with Manchester United and those people around them.
This is even worse.
And this nonsense about Chelsea, you have to cut out. This is a national TV. Come on.
Where's Theory? I'm sure he's
sorry, Doctor.
under a rock.
The floor is for you.
Mr. Haile, we'll bring you for sports next time.
Yes, okay.
And we'll deal with Man U properly.
Yes.
I don't know anything about sports, so I'm not going to go there. No, I'm not a football fan, so I don't know what Chelsea and Manchester United
No, you're fine.
Basically, I think, let me stick to talking about malaria. Yes, when it comes to the MDG Goal 6, the aim was to reduce mortality and morbidity due to malaria by at least 75%, looking at the figures that we started with 2000 figures. When it comes to Ghana, I think we overachieved the target for mortality due to malaria, because in 2000, mortality due to malaria, the case fatality rate, that means of those who get malaria, the proportion who die from malaria. If you take 1,000 people who get malaria, we're seeing about 140 people dying from malaria. In 2014, we're seeing less than 6 people dying from malaria. So in terms of mortality, we have done well. In terms of morbidity, however, which has to do with the disease, those who fall sick, that we didn't achieve our target, in the sense that around 2011 onwards, we rather saw an increase in the number of cases. But we have attributed it to a number of reasons, in the sense that our surveillance system, our system for counting and recording the cases due to malaria improved. And health insurance was also a very big factor in getting people to the hospitals. So in terms of that, we haven't seen the cases recorded for malaria going down. With the interventions related to malaria, where we're supposed to ensure that 75% of people at least have all the interventions. If you take ITN ownership, that improved. It improved. The last DHS that was done last 2014, I think around 68% of households own ITNs. So we didn't hit the 70.
The treated net.
Yes.
Okay.
But if you look at the figure in 2003, we had just about 4%. So it's a great improvement.
Yeah, that is.
Same for IPTP, which is the intermittent preventive treatment in pregnant women, where we have about 60% of pregnant women having at least taken twice the dose, as compared to the figure of 13% in 2003. However, with the use, when it comes to the use of ITNs, we didn't do as well as the ownership. There's always been a lag behind when it comes to use and ownership, because people have the net and they don't use it. Yes. So we've made moderate progress towards the MDG goals, but
I think the one with the mortality,
that is a good plus for us, and we really want to get to near zero deaths where people don't die from malaria. So we still have some work to do, and to make sure that we get there.
That's a nice overview of our report card for malaria. Yeah, let's go to Mr. Haile.
Yes, HIV is one of those areas in the Millennium Development Goal that has achieved what was set out in the goals. We have been able to cut by half new infections. We have been able to also reduce deaths due to AIDS, and also I'm speaking now globally, and I'll come to Ghana specific. And also we had targeted 15 million people to be on treatment, and that was also achieved. So all in all, the AIDS response globally has come up with 15 very interesting and high impact lessons for us in the future, both in dealing with infectious diseases as well as also dealing with HIV itself. So the progress has been registered, and it has been one of the good examples for MDG6, and also malaria globally also has made tremendous progress. So basically MDG6 more or less has been achieved, and also there is TB in the MDG6 as you know, and I think the only chronic problem with TB is some people are resistant to the drugs, and I think that's the only area that is really critically difficult to manage so far. But I think other than that, it has also achieved a lot.
Okay. Yeah. And coming to you wanted to come to Ghana specifically.
Yes. Okay. And Ghana is one of the top 21 countries that have achieved all its goals set out in its strategic plans of, in terms of HIV, in terms of reduction of new infections, over 50%, in terms of averting deaths due to AIDS, almost around 50%, and reduction of mother-to-child transmission. It's almost, I mean, we estimate that we have about 5 infections a day. That is completely nothing from where it was when we started, 200, 300 a day, and so on.
It was 200 to 300 a day, and now it's down
it has really come down tremendously. But what we have not yet focused on right now, and it is again a matter of programmatic focus, is really to pin down these areas where we have high burden of HIV among pregnant women, and pin down to those areas where we're getting those infections. And I think Ghana, if not the second, should be the third country in the world to declare AIDS generation, a generation free of AIDS soon after Cuba. So there has been a lot of progress. But what we like to do here is not just see comparing Ghana to other responses in terms of results, but also seeing the response itself and understanding where are the bottlenecks, where are the challenges, where we need to refocus our energies, and also how to better use efficiently the meager resources that we're having. If you hear anything like in malaria and HIV and TB, something has gone down, we are seeing an increase of this or whatever, you need to understand that as you climb down to your target like this, there's always a wave like this. Okay. It's always a wave. Yes. So that up and down, as long as the general trend is showing something that is going downwards, then these waves inside are always there. So it's not really something to panic about. But also a lot of our responses are also linked to resources as well. So over time, resources have been declining, and that decline in resources also now affects programs. And then you see these waves again. And in the case of HIV and AIDS, we've had several waves that really affected the response. First, we had, if you remember, the year before last year, the 131,000 condoms, fake condoms that were imported into the country. So we had to clean completely that entire shipment, and it took time to replace.
So these are obstacles that crop up.
Yes, it created a shortage of condom in the country. And then we had several stockouts of ARVs as well. So there are also effects of that you will see down the line in a few years.
Okay.
And also the medical store went down in
yes,
fire
so
early this year with about close to 40-something, $60 million worth of HIV stuff. So
but you mentioned funding.
These things, yes.
And we want to talk about that as well, because when the UN set these goals and countries signed up to achieve them, what was the discussion on how all of this would be funded? Is it part UN support, part individual country mobilizing resources, and how to sustain that funding so that, like you said, those waves of support coming in and out aren't too devastating to your efforts?
We see at the UN, at the UN, let me just give one thing. At the UN, when these kinds of decisions are made, they're usually made at the General Assembly. Okay. Meaning the governments themselves who go to sit there are the ones who make the decisions. And once those decisions are made, then the UN takes up the mandate to support these very governments that have made the decision to implement what they have to do at the country. So these are the linkages. So when the UN decides, that means the government has decided. So always the responsibility, primary responsibility of looking after that particular mandate is the government.
Is the government, yes. Okay.
If you look at malaria with the achievements that we've had so far, there was an increase in over 2,000% of funding globally. Okay. And you realize that most of that funding came from donors for countries and things like that. With the current SDG goal, where malaria, we've moved on to develop the global technical strategy to achieve these goals, you realize that we have the aim of interrupting transmission. And one key pillar for us to do that is to increase financing both internationally and domestically. The good thing about domestic funding is that it gives you a lot of room to implement things within a short while without not having to go through cumbersome processes. And I can give you an example of a country in the Eastern African country where they had funding from donors, which is very good, and donors have been supporting us for a while. They brought malaria down, really down in a district. Then unfortunately the funders had to withdraw. Then we saw an outbreak of malaria, high deaths. And it's been about over a year. They haven't been able to curb that outbreak because yes, we are still struggling. But if it's domestic funding, the government can decide within a week or two, once you provide concrete evidence to say that moving this, moving that. So then you may even save, you act quickly, much more saving. And with interrupting transmission, as you go down, like he said, as you go down, it becomes much more difficult to reduce your burden. So you need to put in a much more effort. You need to improve your surveillance system much more. And you get to a point where even when you get one case, that whole district is on their feet because you want to investigate how did the one case. We are not there yet because we still have high numbers. I mean, so the key thing is resources. Resources, funding, either internationally or locally. And domestic is key.
Now, I want to dwell on the mobility aspect of it that you're talking about. I want to know the constraints. For example, you cited the situation where people have access to the net, but they are not using it. Now, we've been advised to keep our gutters clean, to clear filth and so on and so forth. Whose responsibility is it? And how well are we engrossed in this such that it can eradicate the malaria thing in this country?
I think it's everybody's responsibility. You have a responsibility, I have a responsibility, depending on the position that we find ourselves. In terms of the use of the interventions that we have, a lot of it has to do with behavioral change, and it's difficult to get people to change their behavior. If you talk about the gutters and things, if you look at the developed world, most of these areas are covered, so the breeding sites are reduced totally. We still have areas where we have mosquitoes, all right, but because of the ability of the country to clear the parasites in people, the mosquitoes are not spreading malaria. So it's got to do with behavior, it's got to do with development, and it's got to do with the resources to drastically reduce the parasite levels.
Right.
Unfortunately, we have challenges with where we are, climate. The climate here sort of is so conducive for the mosquitoes that transmit malaria. And unfortunately for us, the mosquitoes here are so efficient. Yes, if you compare what one mosquito can do in Ghana as to what one mosquito can do in UK, it's not comparable. So we do have those challenges.
Even our mosquitoes misbehave.
Yes, but even so, those are things we might not be able to change. But the ones that we can change, behavioral patterns are a major aspect of it, and then resources to be able to cover the things that doesn't really depend on behavior to clear. So
there are actually budget allocations for these programs, and so Mr. Tekbe has fashioned out.
It's been said, but as to when it's going to be paid, that is the issue. But I mean, there are schools, there are platforms that we can use. Either you go to the primary school, secondary school, or the tertiary institutions. These are places where a lot of people assemble as a unit, where we can target them. So why can't we do that?
You see, malaria, for example, is one of those types of diseases that has been there for a long time. Societies somehow have either learned or not learned to cope with it.
Okay.
And it is also the primary preoccupation also in terms of its effect on the family, in terms of its effect on the community. So these are the kind of diseases that you use as excellent entry points to domesticate the response at the community level. And when communities are fully involved, then they know which area the mosquitoes are breeding, so what they need to do with that pond there or that water the body there, or what they need to do also within themselves in terms of increased use of bed nets and also reporting immediately whenever there is an incident. And these kinds of things are really community based, and the strength of what we have at the community base is what will tell the success rate of the response. There are countries now in Africa who probably can compare the same mosquito with, instead of with the UK, for instance, who have managed to effectively mobilize the communities so that these transmissions have come down. I know of a country that has been reporting less than 60 incidences, not death, incidences a year, with malaria. So these are achievable things, and that's why also the latest malaria program, which has a very big component of community-based awareness, is beginning to give result. I know from a program point of view, you see all the problems, but really, generally, when you see this is one of the best malaria responses.
Yes, otherwise, I wouldn't be sitting where I'm sitting. Because you see, for a program, you always have a focus at a particular time.
Right.
We had very high deaths. We had very high morbidity. So that was our focus. We don't want people to die. Now, less and less people are dying. So you want to move to the focus of interrupting transmission. Because, I mean, you wouldn't start interrupting transmission and people die. So it's a focus at a particular time, depending on where you are. So we have reached a point where we have to refocus and still make sure people don't die, but add other things to make sure that we interrupt transmission. And it's a whole process. We are starting, we need political commitment, we need community involvement, we need resources. And I think it's achievable because it is achievable once we put in the right resources.
How easy has it been as far as tracking data for these programs? We know sometimes we have challenges with that in this country, but for instance, recently we know the Ministry of Gender announced that they're going to have this National Household Registry to try and identify people in the most deprived areas of the country. Have you found it a bit challenging to identify the areas where you really need to focus your efforts and your resources, or has it been relatively simple to identify who really needs this support and communication the most?
Well, when it comes to HIV, malaria, and TB, these three areas are probably the most resourced as compared to many other places, like what now the Ministry of Gender is trying to do. So over time, we have developed a very robust data system, data collecting system, and verification system. And also, the quality of data is also improving really rapidly, and the report we're getting from the national authorities is always close to accurate.
Okay.
But all the time, like I said, and also she mentioned, there's always a time where you focus, refocus, and then also adjust things. So in our data system now, we are also talking about major data cleaning, because over time there seems to have some disparity. We seem to have some disparity between national data and facility data.
Okay.
So we need to start to reconnect these. And some of these places are also very remote. And for any information to get from that point to the national level, it is a long journey for this data. So we're trying to also introduce some technologies that will cut this out. And we're even talking, I don't know if that discussion has yet hit the real tables yet, but we're also talking about, how about if we use these small drones that will carry samples, lab samples from the very remote areas, and get them to a major big lab center where they'll be analyzed, and immediately the results will be given back. Because some people may be having a problem, but getting their samples on time and having a lab test and giving them the result in between, a lot of things happen to the patient. So the data system is quite robust in Ghana.
Doc, let's talk about concentration of where malaria really affects people. Urban, rural?
For malaria, it's more concentrated in the rural areas. Due to a number of reasons. We generally have low urban malaria because the mosquitoes that transmit malaria usually don't breed so well in the gutters that we have in the urban areas.
You know, they are really they are really dirty gutters, and it's not conducive for them.
Isn't that weird?
Yes. So even though we have a higher population in the urban areas where there are more people, there's lower malaria. Also in Ghana, if you look at the 3 northern regions, malaria is relatively higher compared to the coastal areas. But the good thing is, if you look at from 2011 to 2014, the surveys that were done, there has been great reduction in the prevalence of malaria in the northern sectors, much more reduction than in the southern sectors. So
what has worked with it?
Actually, if you look at what is happening, we are doing things like indoor residual spraying in the northern parts, which we are not doing down here in the southern parts, so that's helpful. And things like galamsey, especially in the western region, we think is having a terrible impact on malaria because it's creating more and more breeding sites for the mosquito that transmits malaria. So we are looking for more resources to be able to continue the indoor resources. Indoor residual spraying, and even introduce additional interventions to try and bring the malaria down.
How do you trade information between and among stakeholders? So, for example, you identify that like galamsey is one of the key issues that causes this issue of malaria. Who do you send the messages to? So that they need to work on it, and then your work will be made.
Okay, so I sit at the national level, but I'm part of the Ghana Health Service, and the Ghana Health Service spans through the whole country. So we have the national, the regional, the district. What I see at the national level, the regional director of health there will also see. What will happen is we collaborate. I wouldn't go down and tell the regional, but we collaborate, we discuss. Once we are seeing this, we draw the attention. Sometimes they even see it even before we draw the attention. And they work with their district to ensure that these things are managed. For example, for the galamsey issue, it goes beyond health sector. So then they would have to work with the other agencies, local governments, chiefs, to try and curb or manage the galamsey issue so that the breeding sites are reduced. So it's mainly a lot of the work is done at the regional and the district levels. We are setting the policies and getting resources.
No, I say so because when you do all the good work, and those who are the connectors are not doing equally what they have to do to ensure that your work is properly done, then you come back to the same point.
You see, just before he comes, you see, it's a whole system. a lot of work is done by the regions and the districts. So they do the good work. Whatever if the regions and the districts are not with us, we are not going anywhere.
Yeah.
So they do the good work. We just support them to be able to do the good work. And then sometimes there are challenges, and we support them to surmount those challenges. So the work is done.
I think what you're asking is a more of an issue in terms of intersectoral communication. Which more than the other diseases, HIV is better in doing, because it has a coordinating body for HIV, the Ghana AIDS Commission, which brings together over 17, 18 sectors as in that commission. So it coordinates across sectors. So it has a view on poverty, it has a view on violence, it has a view on gender issues, on education, on health, on various. So health is one of the partners in that bigger multi-sectoral response. So this issue of galamsey and other similar issues that affect processes, there's always that platform for information exchange and also review of certain policies. But some of them are also beyond the sectors themselves also. I mean, galamsey, we have seen the president had set up a team, task force. They had been allocated with army units. They have been, but it is not really stopping galamsey. So the problem is deeper than just the sectors, and I think there is a lot more to do with how land is acquired and how these equipments are moved into those places and who benefits from that and so on. So that's a big subject of its own. And it's not only on malaria, but overall environmental impact and health impact on people, and also shifting labor and opportunities of young people as well away from schools and other places. This has created a major havoc, I think, in overall speaking. And this is now a national issue, or should be a national issue, as it is one of the determinants that is holding us back in terms of making progress. Yeah.
As Dr. Ma mentioned before, we're all stakeholders in combating a lot of these diseases. And we see ads all the time, public service announcements for preventing malaria and for AIDS. We had the Protect the Goal campaign and things of that nature. So with all these initiatives that you put out to try and educate the public, which ones do you think resonate the most? Is it a TV ad? Is it a flyer? Is it a town hall meeting in local language? Like, what do you think really makes people connect with the issue and want to be part of the solution? Dr.
Who you are talking about and who you're targeting at that particular time. Say, for instance, if we take the Protect the Goal campaign, for instance, it's a campaign that is more or less designed towards the youth, and in specific also the urban youth and the urban middle class. So therefore it resonates well when the faces and people like yourselves that we have used to communicate make sense, and also the messages go out. And then on the other hand, within the same HIV, for instance, you have what we call heart-to-heart ambassadors. They are more focused on stigma and discrimination. So in that sense, that audience is picked up through media, through the ambassadors, through the various caravans that they use to move around various parts of the country. So it does make a difference on who you're targeting and how you do it. But yes.
Doc, briefly.
I think it also depends, like he said, on who you are targeting. But since for malaria, it's everybody who is affected. One of the things that we see that resonates well with people is when the community level engagement, and in fact with the media, the mass media one, the radio and the TV. The radio works much better with the rural areas, but with the TV, which is also quite extensive, it's like fire when it comes to the urban areas. So it also depends on whom you are targeting. So that's so we do everything for malaria.
But generally speaking, from the media point of view, though, I think there needs to be more work. Yes,
we shall do more. We also need funding.
When I sit, when I sit and watch Viasat, I am one of those restless kind of people who does well with 1 hour, 2 hours sleep, 24 hours. And Viasat is one of the stations that I see almost round the clock. And the amount of time that you have for films and other entertainments and whatever And the amount of time you have for us here is just not
You can
comparable.
do better.
It's just not comparable.
Thank you so much, Doc. We'll ensure that
We're
we do
struggling
whatever
with
they're
funding.
saying.
We need funding.
We shall do that. We shall do
Yes,
that. And
no,
it's a
but
promise.
we will.
It's a
we will.
promise.
Thank
Okay.
you
Thank you
for bringing your
coming on the
learned
show.
selves here
Yeah.
this morning. Always
Okay,
great.
so
Always great. to
see
have
you
Thank
sometime.
Thank you for having
When
us.
the
Yes.
100% achievement is.
you. No, we'll touch base regularly.
Okay, so there we go.
I know, much
so,
love and peace.
From Cookie, Patrice, Mr. Haile, and
And Dr. Mo.